The main incentive for me to start using Lenstar as my preferred biograph was my interest for toric lenses in my cataract practice. To implement toric lenses in a busy practice is crucial that you have a good patient flow. As we started with toric IOLs almost 8 years ago, and at that time manual Cheval keratometry was the only method approved. This method for power and axis of the toric component was accurate and precise, but very time consuming. To speed up the preoperative patient flow and to standardize the procedure, we started using the IOL master for the keratometric measurements. It was not as good as the Cheval, but we ended up with quite nice clinical results. Since the Lenstar biograph has double rings of measurement points and twice the number compared to IOL master, we were keen to start using it for toric patients, believing that it would give us better clinical results. We have experienced that Lenstar is easy to implement in a busy practice, it's fast and effective, but the most important is actually the good clinical results that we get. Based on Lenstar measurement as the only keratometric data, we end up with close to perfect spherical results and a mean rest cylinder of approximately 0.45. The combination of double ring measurement points give us exact information about both cylinder power and axis, which can easily be used in the Acquisitive toric calculator for a thorough preoperative IOL choice. In the present study, we ended up with 96% of the eyes ended up with a sphere less than 0.5 after 3 months, which we found really exciting. All eyes had refractive astigmatism less than 1 diopter, with as much as 65% with less than 0.5 diopters of astigmatism. We found that 89% of eyes had uncorrected visual acuity within 1 line of best corrected visual acuity. And this really indicates that we have close to perfect postoperative refractive status. To summarize up what I feel is the main criteria for toric IOL success. First, effective patient flow, fast and effective biometry as performed with Lenstar. We need good surgical planning and a wide range of toric IOLs in stock. Prior to surgery, thorough marking and good implantation technique is crucial to the postoperative results, and after surgery we have to follow these patients on a thorough postoperative control. My final remarks would be that Lenstar is fast and efficient. It allows effective patient flow. Lenstar is accurate and precise and provides a reliable preoperative biometry. The refractive and visual outcome is promising. In the present study, we found excellent uncorrected and best corrected visual acuity after toric eye implantation. And I find that the extra work and cost for toric procedure that we put in is worthwhile both for patient and surgeon.
Hello, I'm Warren Hill from Mesa, Arizona. Let's talk a little bit about the toric IOL and the measurement of corneal astigmatism. We all love the toric IOL, but sometimes the measurements that we do before surgery have a little bit of doubt. And I'm going to show you some ideas that may help erase that doubt and may make putting in the toric IOL just a little bit easier. First of all, let's talk about the distribution of corneal astigmatism in our patients. Of course, we all remember the 3 diopter astigmat, but it's really the lower value patients that are the ones that we see more commonly. So for patients who are going to get say the T3 through the T9, about 52% of those patients walk in the door. But if we include the T2, that would be 72% of patients. So for people looking to add the toric IOL to their armamentarium, to have over 70% of patients as potential toric IOL candidates is huge. But in order to get these low astigmats, we have to do the measurements correctly. So what is it that we're looking to do when we do preoperative measurements for the toric IOL? Well, forget about the fact that you're getting a set of Ks. That's not really what you're doing. This is completely different than determining the spherical power of a lens. First thing we're looking to do is to determine the orientation of the steep and the flat meridians. And for the low astigmat, that can be very difficult. The second thing we're looking to do is establish the power difference between those 2 meridians. So this is what we do with the toric calculator. We find out what is the steep meridian, what is the flat meridian, and then what is the power difference between. Now, let's talk about the humble keratometer, a device from the mid-19th century. Why is this still considered the gold standard for preoperative toric IOL measurements? Well, it may only measure 2 points in the steep meridian, but it turns out that they're the correct 2 points, and the user can take their time and figure out exactly what the proper meridian needs to be. Rotate the same drum 90 degrees, and that gives you the flat meridian. So here we have the 3 things that we need for the toric IOL: the orientation of the steep meridian, the orientation of the flat meridian, and then the power difference between. And again, the advantage of this is the user can take as much time as they need in order to do a good job. Let's talk about the IOL Master. The IOL Master certainly is a device that's widely in use, but the IOL Master may not do the best job for determining the orientation of the meridians. And why is that? Well, this is what's going on behind the curtain. We only have 6 measurement LEDs that are spaced 30 degrees apart. And if the steep meridian's at 0, 60, or 150 degrees, chances are the machine's going to get it right. But if the steep meridian's between those, that's a 30-degree difference, and you may need to have a lot of iteration going on in order to figure out what the correct alignment is. So if we look at this number right here, you can see that the steep and the flat meridian are very far away from the measurement points, and it can be a problem for us. If we look at the Lenstar has 2 rings of 1.65 and 2.3 millimeters, and it takes a total of 640 measurements. So here's the first ring, and there's the second ring. So not only do we have greater density of measurement points, but we're actually measuring things twice. So if we look at this third measurement here and put in the steep and the flat meridians, you can see how close they are to the measurement points and why we do a much better job. There was recently a paper written by Bobby Osher, Kerry Solomon, and myself showing equivalence between the Lenstar and manual keratometry. And again, manual keratometry is considered the gold standard by most of us who use this IOL, and also the manufacturer who makes it. So in summary, closely spaced dual zone autokeratometry is by far an accurate way to determine both the location and the power difference between the principal meridians. As I mentioned, Lenstar Ks are equivalent to manual keratometry, and that is considered the gold standard for measurement of corneal power prior to placing the toric IOL, and this was recently confirmed in a study in the Journal of Cataract and Refractive Surgery. Additional precise axial measurements such as the anterior chamber depth and lens thickness really do add to precision, and our toric outcomes using only the Lenstar for the preoperative measurements have been excellent.